Anticholinergic drugs block the actions of acetylcholine on autonomic effectors and in the central nervous system via muscarinic receptors. While nicotinic receptor antagonists also block certain actions of acetylcholine, they are typically referred to as ganglion blockers and neuromuscular blockers. These drugs are essential in various medical applications, particularly for their effects on the parasympathetic nervous system. Atropine is the prototype drug of this class, highly selective for muscarinic receptors. It can be demonstrated using a piece of guinea pig ileum, where acetylcholine-induced contractions are blocked without affecting those evoked by other spasmogens like histamine and 5-HT. At high doses, however, this selectivity is lost. All anticholinergics act as competitive antagonists. Anticholinergic drugs are classified into natural alkaloids, semi-synthetic derivatives, and synthetic compounds. Natural alkaloids include atropine and hyoscine, scopolamine. Semi-synthetic derivatives include homatropine and ipratropium bromide. Synthetic compounds are further divided into mydriatics, antisecretory antispasmodics, vasocoselective, and anti-Parkinsonian drugs, each with specific examples like cyclopentolate and trihexyphenidyl. The effects of atropine can be largely predicted based on parasympathetic responses. Significant effects are observed in organs with strong parasympathetic tone. Atropine blocks all subtypes of muscarinic receptors, leading to various physiological changes. These include effects on the central nervous system, cardiovascular system, eyes, smooth muscles, glands, and body temperature. Atropine generally stimulates the central nervous system, but these effects are not significant at low doses, which mainly produce peripheral effects due to limited brain entry. In contrast, hyoscine can produce central depressant effects even at low doses. Atropine stimulates many medullary centers, including the vagal, respiratory, and vasomotor centers, and depresses vestibular excitation. The most prominent effect of atropine on the heart is tachycardia, caused by the blockade of M2 receptors on the SA node, reducing vagal tone and increasing heart rate. Initial intramuscular or subcutaneous injection of atropine may cause transient bradycardia. Atropine shortens the refractory period of the AV node and facilitates AV conduction, especially if high vagal tone has depressed it. Topical instillation of atropine causes pupil dilation, mydriasis, abolition of the light reflex, and cycloplegia, paralysis of the ciliary muscle, lasting 7-10 days. This results in photophobia and blurring of near vision. Intraocular tension tends to rise, especially in individuals with narrow-angle glaucoma. Conventional systemic doses of atropine produce minor ocular effects. Atropine relaxes all visceral smooth muscles, receiving parasympathetic motor innervation. In the stomach and intestine, it reduces tone and amplitude of contractions, slowing the passage of chyme and potentially causing constipation. Spasms may be relieved, but peristalsis is only incompletely suppressed. Atropine also causes bronchodilation and reduces airway resistance, beneficial in COPD and asthma patients. Atropine markedly decreases sweat, salivary, tracheobronchial, and lacrimal secretion, leading to dry skin and eyes, and difficulty in talking and swallowing. It decreases the secretion of acid, pepsin, and mucus in the stomach, primarily affecting the volume of secretion. Higher doses are needed to reduce acid secretion, and atropine is less effective than H2 blockers. High doses of atropine can cause a rise in body temperature due to inhibition of sweating and stimulation of the temperature-regulating center in the hypothalamus. Children,